Good evening, everyone. Thanks for joining in. My name is Dr. Ruben Manohara. I'm an orthopedic surgeon from Singapore. I'm in private practice. I'm in the Shoulder Elbow Orthopaedic Group. I'd like to thank the organizers for their kind invitation to be a part of this exciting meeting. The topic I'll be talking to you about would be how to avoid complications in clavicle fracture fixation. So what I'm going to cover in this talk would be briefly the anatomy of the clavicle, what are the complications of treatment, and then we'll go into how can we prevent these complications with a focus on the evidence behind the superior versus anterior plating, the various clavicle plate options, as well as plating versus intramedullary fixation. And then we'll just summarize it and then have time for a Q&A after that, hopefully. Okay, so as you all know, the clavicle is an S-shaped bone on the shoulder girdle. It's got an intramedullary canal in the middle portion, but the lateral and the medial portions actually do not have a patent canal. It's fairly solid. On the medial side, there are the strong sternoclavicular ligaments that attach it to the manubrium. And on the lateral side, there are the strong coracoclavicular and acromioclavicular ligaments that stabilize it to the acromion and the scapula. Right. The reason 80% of all clavicle fractures are mid-shaft clavicle fractures is because, one, the S-shaped configuration, that is a point of weakness. Two, the ligaments on either end are strong stabilizers. And three, the muscle coverage, there's a lot of muscle coverage over the medial and lateral aspects, and the middle portion is relatively uncovered. This is why the majority of the fractures, 80% rather, are mid-shaft clavicle fractures, and they have the typical deformity from the pull of the sternocleidomastoids, the trapezius, the weight of the arm, and the pec major. Sorry. What are your neurovascular structures at risk? Well, your subclavian vein and artery are at risk. You look at the photo here. In the medial third of the clavicle, they are directly posterior to the bone, whereas in the lateral 2/3 of the clavicle, they are inferior to the clavicle. So this, would be very important if you're planning to do superior plating in this portion or anterior plating in the medial portion. Okay, the brachial plexus similarly is at risk in the middle 1/3 of the clavicle over the inferior aspects. Okay, the measurements as noted. Another important neurovascular structures to know would be the superficial cutaneous nerves, supraclavicular nerves over the clavicle. Usually, there are 3 of them, but usually in your dissection, you probably encounter 2. Now, if these are not handled properly, it could lead to painful neuroma formation or worse, even CRPS, which shouldn't occur just after a simple clavicle fixation. But you can see in the literature, the post-op sensory disorder rate can be as high as 83% if these are not handled properly. So what are the complications of clavicle fractures? Well, conservatively managed, we worry about non-union and malunion. And that's why we do surgery, right, to minimize the chances of this. Okay. Now, we know for non-union, there are actually patient factors that contribute a lot to it. Females, heavy smokers, the elderly, those with multiple medical comorbidities. And then there are also fracture factors. Those fractures that are highly comminuted, very highly displaced or associated with high energy trauma are all at risk of non-union. Okay, and with malunion, we worry about that the shortening or the angulation of the deformity may give rise to fatigue with overhead activities, thoracic outlet syndrome, or just cosmetic problems or difficulty with like seat belts and shoulder straps and harnesses, etc. Now with surgery, even though we minimize the risk of non-union and malunion, there's still other risks to worry about, okay, namely infection, pneumothorax, vascular injury, nerve injury and nerve complications, hardware prominence and the need for a secondary procedure. This tends to be the commonest complication of all. And despite proper surgical techniques, sometimes you can still get non-union mechanical failure as well, with plate fatigue, plate failure, breakage, and screw pull-out occurring, and secondary frozen shoulder. So the aim of the talk to be look through the risk factors and how we can minimize these complications. Okay, so first up, infection. How can I prevent it? This is fairly common sense. I would say the use of appropriate perioperative antibiotics. Usually a single shot induction should suffice. There isn't a need to continue this post-operatively as well. If there are associated wounds or abrasions, you might want to consider delaying the surgery till they have healed or until they are dried up. Either that, or if there's no choice, the planned incision should skirt the affected areas if possible. Otherwise, you can also consider an MIS technique where, if the abrasion's in the middle, you just make your incisions at the distal and proximal aspects and slide a pre-contoured plate and fix it there so that you're avoiding the area at risk. Of course, proper tissue handling and aseptic technique is imperative in infection prevention. So what about the pneumothorax and vascular injury and nerve injury? So this comes down to appreciation of the anatomy. Okay, pneumothorax is, now the lungs are here, and so if you're doing superior plating, you shouldn't plunge your drills down. So you should control your drilling. Either that, or if you can't trust yourself, do an anterior plating, and then if you're drilling in an AP direction, the chance of you getting a pneumothorax is pretty low. Okay. Similarly, for vascular injuries, you should just control your drill bits, especially when you're over the middle third, if you're doing superior plating. Otherwise, anterior plating is much, much safer. Okay. Nerve injury, same as well. But I would also make special mention of identifying these supraclavicular nerves. And then you either decide, are you going to cut them or are you going to preserve them? Both are fine. I normally identify them and I cut them under tension so that the nerve ends retract into the muscles, and this prevents neuromal formations. Of course, you need to tell the patients beforehand, look, I'm going to do this. There will be a patch of numbness. Otherwise, you can always just preserve it, and it's just a bit more filial during the surgery. It's personal preference. I think as long as the patients know beforehand if they're going to have numbness or not, they'd be quite accepting of it after that. How about hardware prominence and the need for secondary removal procedures? Well, there's overwhelming evidence for this, that anterior clavicle plating has lower incidence of removal procedures. Okay, multiple studies have shown that superior plating has a higher rate of symptomatic hardware compared to anterior plating. The rates of removal can vary from 5 times to 7 times to 2 times, depending on which study you want to look at. Okay, you can see here, the first study here, first study here, superior plating had like a 2 times higher rate of implant removal. In this study here, the odds ratio for secondary procedures 5 times higher in the superior plating group. And I think you find most studies that are studying anterior and inferior plating will quote like a 5 to 6% rate of hardware removal, if at all. What about biomechanically? Is there any difference between anterior and superior? Well, superior plating does better in torsion in terms of stiffness and failure under torsion, but anterior plating performs better in terms for 3-point bending in terms of stiffness and the failure load that it can tolerate. So I guess the jury's still out, which one's better biomechanically. Now, how can you prevent these complications, non-union mechanical failure, when you're operating? Now, we know that the patient factor, so can you choose your winners? Unfortunately not. You have to take what comes to you. I guess you just have to exercise caution when you have the female, the elderlies, the heavy smokers, those with multiple medical comorbidities, or very comminuted displaced fractures. Open fractures, so they have a slightly higher risk of non-union as well, though there's not much literature on that specific to clavicle fractures. What about surgeon factors? You want to minimize soft tissue stripping of the loose comminuted fragments, because once you just want it to key in and you strip off all the attached muscles, then it becomes an avascular piece. So that's not much use at all. So if you want to minimize that stripping for the loose comminuted fragments, you want to ensure good solid bony contact and then locking compression plating. Okay. Now, the various clavicle plate options, I'm sure you've seen them and used them yourselves. You've got your typical dynamic compression plates, your recon plates. Some people like the 1/3 tubular plates because of their lower profile. And there are a lot of fancy anatomical clavicle plates now, superior plates, superior anterior plates, and pure anterior plates. So what's the evidence for it? This slide I just got off the internet just to show that, despite all these plates, you still see things like, plate bending, plate breakage, screw pull-out occurring. And this is a locking plate, mind you, but the surgeon had used cortical drills, just bicortical screws, and it still pulled out. He didn't lock them in this case. So this study was looking at 102 clavicle ORIFs, comparing 2.7 recon plates, 3.5 recon plates, 3.5 pre-contoured non-locking plates, and 3.5 locking compression plates. They found there were 3 cases of non-union, but there were multiple cases of hardware failure. The 2.7 recon plates were breaking, the 3.5 mm recon plates were deforming, and both the recon plates and the non-locking plates were having a screw pull-out as well. So, you know, I think in this day and age, I think locking compression plating is a fairly safe option for your clavicle fractures if you're worried about non-union. What about plating versus intramedullary fixation? Well, intramedullary fixation, yes, is less invasive. There's a smaller scar, but it does have poorer rotational stability and scar complications at the entry points, and a higher risk of non-union and risk of migration if you're just using something as fiddly as a K-wire. Okay, the plates have performed better than intramedullary devices in terms of union rates. However, there are some concerns about higher infection risks with open plating. Depending on which article you're referencing, sometimes they do seem to have similar results in terms of their post-op clinical and functional and patient-reported outcomes. So my preference is to do anterior locking plates. I find, whether it's 4 comminuted fragments or just 1 comminuted fragment, all my post-op x-rays all look the same. It's very easy, and there's no implant prominence, especially if it's a male. The only 2 times I ever had to remove a plate after this, they were both in very young females in their 20s who had very little subacute fat or muscle bulk, and they felt it was prominent and it had to come out. The rest of the patients with the anterior clavicle plate don't have any complaints. And finally, secondary frozen shoulder. Well, early mobilization, that's the key. So for that, you need rigid, strong fixation at day 0, and for that, you need like locking compression plate. Ensure that there's adequate bony contact. And what I do post-op is I allow them immediate active range of movement is tolerated. I let them do passive and loading from about 4 to 6 weeks from the surgery. You might want to avoid overheads for the first 4 weeks as well, but as long as they're moving it from the go for their daily activities, usually this isn't a common problem. Okay, so in summary, we've gone through the anatomy, the complications of treatment, and how to prevent these. Come to the end of my talk. I'll be very happy to take any questions now. Once again, my name is Ruben Manohara. I'm from the Shoulder Elbow Orthopaedic Group in Singapore. Please feel free to drop us an email, or you can drop us my personal email there if you have any questions. Thank you.